Cool. So it's 6:30. We'll make a start. Good evening, everyone. Welcome back to our ABCD and P of Anaesthetics series, presented to you by the Pre-Vocational Anaesthetics and Critical Care Society. My name is Mason. I'll be hosting tonight's event. The topic for tonight is on circulation. Much like the past few events, we aim to keep the session short, at about 30 minutes long. We'll have about 15 minutes of question time at the end. So please use the Slido link in the chat to ask all of your questions, and at the end I'll select the most thumbed up questions at the end to ask Greg, our speaker tonight. Unfortunately, we won't be answering any questions in the Zoom chat as we won't have time to go through them all. But yeah, again, please use that link that we've provided. This session will be recorded, so please like our Facebook page and join as a member, which is completely free, to have access to our recording and other resources. Okay, now it's with my great pleasure that I introduce our speaker for tonight, Dr. Greg Evans-McKendry. Greg is a second-year anaesthetics trainee at St Vincent's Hospital, Melbourne. He's had a pretty diverse career, having only done his first anaesthetics rotation in his fourth year out of medical school. He's currently PGY 7, having completed 12 months of ED and 12 months of ICU before getting onto the program. There's a strong clinical interest in point-of-care ultrasound and complex pain management, as well as teaching. Outside of medicine, Greg likes to keep fit with swimming and yoga and enjoys photography and Lego, and is now a proud owner of a chili and miniature lemon plant. So Greg, thank you for spending your Tuesday night with us. I'll pass it over to you and let you share your screen.
Yeah, thanks for having me. And I guess the reason I mentioned that I didn't do an anaesthetics rotation until, can we see that screen, the intro screen?
Yeah.
Yeah, so the reason I mentioned that is that I didn't do a rotation until fourth year is you don't have to put an excessive amount of pressure on yourself to get onto a training program. I only applied once for anaesthetics, but I just did it at the right time. And that's the theme of anaesthesia, making your first go your best go. So generally speaking, I mean, I think this is a cool, and I'll just remind everyone to please put themselves on mute. This is a cool idea. I know that name. This is a cool idea. So bridging sort of the clinical and the theoretical for medical school and being a junior doctor. Cardiovascular physiology is a huge area. So I mean, each topic we talk about today could be spoken about for an hour each. Hopefully, it won't be an exhaustive introduction, but hopefully it's the beginning to thinking like a critical care doctor, because part of being a good junior doctor and a potential candidate as well is showing that you have a commitment to being a better doctor, not simply achieving a desired career outcome. Sadly, all the physiology you learn does matter. As I found out in my anaesthetic exam, I have to go back over it again sometimes, but hopefully through some concepts and cases and a bit of refresher we can go through and just help bridge that gap a little bit. So when we talk about assessment of circulation from a critical care perspective, what we're really asking is, does our exam support adequate tissue and end organ perfusion on the part of the patient? Or if there is an abnormality that we find, is it in keeping with an appropriate compensation for a problem? So remember that we have very well-developed cardiovascular homeostatic mechanisms that we've developed over centuries or millennia, dare I say, and that our treatments can possibly hinder those compensatory mechanisms as well if we don't perform an adequate assessment. So there's things you write on your ward round notes, you know, obs stable, afebrile. It all starts with those, okay? And particular importance is the trend of your observations. And it's not just about blood pressure and heart rate. Okay, so I mean, respiratory rate and oxygen stats can also indicate cardiovascular problems. Can anyone give me a really simple example of a cardiovascular problem that would cause tachypnea and hypoxemia? Feel free to shout out.
Shock.
Yeah, sure. Through like some sort of reduction in cardiac output. I was also thinking of ventricular failure, which would lead to pulmonary edema. But shock is a good one, although there are different classes of shock that we'll talk about a bit later. But if we talk a little bit more about blood pressure, if we put a cannula in the radial artery and we connect that cannula to a fluid column and we measure the pressure changes over the cardiac cycle, we get a little trace like this. You've probably seen it. So, I mean, we have systolic pressure on the top here, and we have the diastolic pressure on the bottom here. Can anyone tell me what this little notch here in the middle is? Or what it signifies?
So closure of the pulmonary valve?
Yeah, so it's closure of one of the valves. It's the aortic valves, because remember, this isn't a radial artery, so we're looking at the systemic circulation. But it's the little pressure spike we get is closure of the aortic valve. And that has importance too for coronary perfusion down the track, which we'll see. But why do we care so much about blood pressure? And I'm going to ask as well, which number in the blood pressure is the most important for making sure we have adequate tissue and organ perfusion? Systolic, diastolic, or mean? Any ideas?
Is it the mean?
Yeah, it's the mean. Because we know from a lot of our research, well, not our research, but general research on physiology, that is often the pressure that regional circulations auto-regulate most off of. But we see at the beginning of the cardiac cycle, or beginning of ventricular ejection, which happens after the action potential has gone through the ventricle, so the Cure's complex has already passed, we get this massive pressure spike, which is actually blood being pushed out by the left ventricle, in this case, into the aorta. And the aorta then expands, takes all that elasticity, and then pushes it down the line into the arterioles and the smaller vessels. So all of this here is systole, even though the pressure is still dropping, because all the blood is actually being dispersed into different circulations. And then we have this closure of the aortic valve, and that's when we have diastole. And this pressure drop here is all the blood, again, perfusing all the capillary level circulation. And does anyone know which artery type is most responsible for protecting the capillaries from receiving too much pressure?
Is it the arterioles?
Yeah, it's the arterioles. They're the thick muscular ones, and they're the ones that actually are involved most in autoregulation. And we like formulas when we're preparing for things. So our mean arterial pressure, which is really important, is often, you might have seen this in the textbooks, it's a little bit hard to calculate though in real time. So we often think about it conceptually, that mean arterial pressure is a product of our cardiac output per unit time multiplied by our systemic vascular resistance, and which is largely determined by the arterioles. And our cardiac output, again, is our heart rate times our stroke volume. So we'll come back to that a few times throughout this talk. But again, all those exam findings that we have, so you look, you feel, you listen, your ECG and your other tests. Now instead of just doing it sort of from start to finish, we should really be thinking about what exactly does this finding mean in terms of tissue perfusion or in terms of the pathology that I'm expecting to find from this sick person. So from the looking, who can identify the most important thing when you're looking at someone that you should be always doing, and then considering whether you should continue with your exam? You don't have to answer. You don't have to answer. It's conscious stuff. Because if someone is unconscious with any problem, you don't then continue your exam. You actually go down to basic life support. And it's important to remember that in any problem you face, even when you're just on the ward, even if you're not at a met call or a code. So other things that are really important. So I mean, you can go through this as well. This is sort of medical student level examination things. But skin turgor and capillary refill, we talk about their importance in pediatrics because they're an additional finding where we can't, supplement our examination with a history from the patient because they're a pediatric patient. But they are often the most sensitive predictors of peripheral tissue perfusion. So skin turgor, particularly under the clavicle, is considered quite a reliable area to sort of test and see whether it has any sort of elasticity or whether it's sort of more like clay or more mushy. And does anyone know, if you can feel a radial artery pulse, what sort of systolic blood pressure you're dealing with as a minimum? It's roughly about at least 80 systolic. So keep that in mind as well. And again, these are additional findings. Now, your charts and your tests should be forewarning you, but I put them here at the end just to neaten up the slides. But they're also very useful, like little clues for things you can look for when you do your focused examinations. Does anyone know a normal lactate level as well on a venous gas?
Less than 2?
Yeah, usually 0.5 to 2. And whereabouts is lactate produced at all times in the human body, regardless of pathology state?
Muscles?
Red blood cells. They don't have mitochondria, so they have to produce lactate for metabolism. But muscles will produce it during anaerobic respiration, during times of stress, you're right. When we think about vascular access, you can have things in veins or arteries. Usually things in veins are for giving. Usually things in arteries are for sampling. So if someone's got DKA and you need to continually monitor their potassium or their pH, or monitoring like in that trace that I showed you. You can have peripheral or central access. Usually central access lines are for giving things that might irritate small peripheral veins. And you can have tunneled lines, which are really important if someone's going to have a line in for a long time, say chemotherapy, to minimize infection risk. And just briefly, this is a 20 gauge cannula that sometimes a medical student might struggle to put in. These are the cannulas that can get put in during an arrest when someone needs volume, say if they're hemorrhaging. They're substantially bigger, but the good thing is you can put this little wire through that 20 gauge cannula and dilate it and turn it into a big, much bigger cannula if you need to. And this is an example of someone who has a tunneled portacath for chemotherapy or long-term intravenous access. And they also have a central line coming in their internal jugular vein. And you can see where the subclavian vein meets the superior vena cava here, because that's where the lines have sort of crossed one another. All right, let's get cracking. So with any clinical case, you always need to ask yourself at the top of the question, how quickly do I need to act? Because do I have time to do a full assessment, or do I need to make the treatment and a decision now or call for help? Don't carry the pressure to solve everything yourself, but do remain critical. Think critically, I mean, because being too suggestive or taking on someone else's opinion might mean you might miss things. You need to be accountable for your own assessments. With any problem solving, you should establish your hypothesis, treat while you're testing your hypothesis, and then reassess whether or not the treatment has had any effect. So you're walking down the ward at 2 in the morning, you're in HMO 2, and you're just called by a nurse who's doing their routine odds. Hey, can you come and have a look at this guy? He's a bit hypotensive. I'm not too worried, but I don't want to call a met call. What can I do? So what's the first thing we want to know? This person has hypotension. They're 91. They've had an intramedullary nail for a fractured femur. You're in the room. What do you want to know? Straight up.
Are they alert?
Yeah, good. So they're sitting up alert and talking. But they're just talking about palpitations, which is a new thing for them. So the nurse is sort of thinking, oh, I'm not really sure whether we should do much. I don't have a cannula. So should we, give him a glass of milk and put him back to bed? Or what else do you think we could be doing or hypothesizing? You'll go to a met call, and any number of these things could be possible, and all of these will happen at a met call at some time in your career. Does any one of those things really stand out as a useful bedside test?
Leg lift, because if his blood pressure goes up, it might mean that he is just fluid deplete.
Yeah, so the leg lift gives about an extra 5 to 10% of blood volume back to the central circulation. And it's useful if someone doesn't have a cannula, and if you don't want to overload an old person who might have heart failure with fluid, to just do that little bedside test. So you do that on him, and it doesn't really change his blood pressure. What else do you want to know? He's talking about palpitations. Is there anything else we want to know about that from a focus point of view?
Get an ECG.
Yeah, fine. He's got an irregular heartbeat when you felt his radial pulse, and we've got an ECG. So whoever said that, let's go through this ECG. You can just give me a diagnosis. There's nothing really scary to be found on this ECG, but we see we've got an irregular heartbeat with its narrow complexes, and we can't really see P waves. So what do we have here?
Yeah, so that's AF.
Yeah. No prizes for guessing that. But this is new AF in a 91-year-old who's just had a femoral shaft fracture and a big operation. So what are some hypotheses about a hypotensive patient with new AF? What sort of things do we put on the consent form for this operation? Why might he have this problem?
So it could be an infection. It could be a new, I guess, something causing like a PE or like a DVT. But my concern would be an infection if it's post-op.
Yep. What other things do you put on the consent form when you're consenting someone for an operation like this?
Could also consider like a fat embolus, given that it's an IM nail.
Yep. There's also risk of bleeding too, isn't there, from a big operation? So how do we test these hypotheses? So we've got an arrhythmia, we've tested that. We've got an ECG confirming atrial fibrillation. That could be a cause or an effect of low blood pressure. But can someone tell me how much the atrial kick in the heart contributes to ventricular filling in a normal heart? Generally about 5 to 10%. Thanks, Joel, you got there. But when you have an atrium that's fibrillating and a thick ventricle, potentially in an older patient who really needs that extra kick from the atria to help fill the ventricle towards the end of ventricular filling or diastole, that atrial kick can contribute up to 20% of ventricular filling. So if that atrium is now doing its own thing and not helping fill the ventricle, we can see straight away that blood pressure might drop again. And another way just to test our hypotheses, what sort of tests can we do to check for infection and bleeding? It could be on history examination or a blood test.
I mean, you could just like look at the wound.
Yeah, so if there's blood pouring out of it or if it looks infected, I mean, second day, you'd be unlikely to be that infected. You could feel his calves, like you say, you might have a PE, although you might expect more of a dyspnea or a tachycardia or a sore leg or chest pain if PE was up or higher on your list. What tests can we do to confirm these hypotheses? Blood tests.
FBE, culture.
Yeah, it's not really rocket science, is it? It's really basic stuff. But what we're doing here is we've been called in to work out a problem. We've now got to test the problem because the guy doesn't have a cannula as well. So we're going to put a cannula back in this person. It looks like at this stage he may not actually make it to rehab tomorrow like was planned. If he's hypotensive with new AF, he's probably got a few things going on. So just to flesh things out a little bit, another useful bedside test can be urine output, and this man was voiding, he didn't have a catheter in, but we found that this person is actually anemic from yesterday. We put in a cannula, taken some bloods, and his creatinines rise slightly, so perhaps he might have a little bit of renal hypoperfusion. So with all these things we put together, we've got to also think about the consequences because, and this is something I used in my interview when I got on the program, I sort of stopped at the anemia. I didn't keep looking because would anyone do a troponin on this guy? Because when I brought it back to my registrar, he thought, oh, you'd probably do a troponin and see what's going on. And lo and behold, he did have a troponin rise. So that's why I always have to go back and reassess and think about what else can be going on. Because, and when we think about, I'll just skip past this ECG, think about perfusion of the coronary arteries, like we say, just which part of the blood pressure is most important for perfusion of the coronaries? Do we know?
Diastolic.
Yeah, absolutely. So this guy's diastolic was 45 and he's got 91-year-old coronary arteries. And even in the absence of defined coronary artery disease, and he's got hypertension as well, so he probably has a thicker heart. So the diffusion gradient for oxygen from the blood into the muscle where it needs to get in the heart is actually likely to be low. Additionally, which phase of the cardiac cycle is the energy dependent part or the ATP dependent part? So it's diastole, because that's the part of which the myosin and actin are actually uncoupled by ATP and put in a higher energy state, ready for the next cycle. It's also this part of the cycle when calcium is extruded out of the cell or back into the cytoplasmic reticulum. So diastole actually becomes very important, and consider that if your heart rate, as your heart rate increases, which it might do if this guy goes into rapid AF, as diastole, as heart rate increases, coronary artery filling time decreases, so the risk of ischemia is even higher. So we need to, again, keep thinking about the consequences of what's going on. And this is just a little graph that shows in diastole, the coronary artery perfusion is much, much greater than in systole, as you can imagine, because the ventricle is squeezing. That's particularly true for the left ventricle, which is much, much thicker. So the actual takeaway message here is not about, really getting down to the nitty-gritty pathophysiology of coronary artery disease, but you need to consider about what you're finding in context of the patient's medical and functional reserve. So if you can start to talk with your seniors about a concept like frailty, ability to adapt to challenges and face physiological challenges, you're going to start to sound a little bit more clinically knowledgeable, because it's very important. Interestingly, you can be young and frail, because if you talk about a 40-year-old, say, with like leukemia or who's just really, really malnourished, and you talk about a 40-year-old frail person, that's when people start, it really conveys a lot about how unwell they are. And this man actually had the type 2 non-STEMI, it's called, which is a bit of a troponin leak, a little bit of heart damage due to hypoxia, due to supply versus demand mismatch. It doesn't really match a specific artery territory, but it's still significant to cause heart strain. And there's arguments about whether someone would do a troponin in a 91-year-old. I mean, what are you going to do about it? But you do need to know that this man actually now has a much higher risk of perioperative mortality. And as a little side note, anyone who's on beta blockers, either on the medical ward or the surgical ward, if they're for an anti-anginal or for someone who has existing AF to control their ventricular response, try to continue them, or at least at a half dose, or get some advice from anesthetics or ICU or cardiology. Even the peri-op medicine physicians are very good with these medicines, because you can get a rebound tachycardia, which can really cause reduction in oxygen supply to the heart. Let's barrel on. So now we're at a MET call for an 18-year-old who's waiting her renal tract ultrasound for pulmonephritis. She's been in ED for about 12 hours, and you're a MET call. She's very hypertensive, tachycardic, and unwell. So the first thing you do is look at the obs to get a trend, of course, and we see this. So we see that this girl's been plodding along. I mean, if she was healthy at home, she might have blood pressures like this and not know about it. But the wheels really start to fall off, apparently, in the last sort of hour or so, apparently. So she's had a few fluid boluses, but didn't really pick up. Now she's got a fever and her heart rate spiked to 140. So what do you want to do? She's sick. We don't really have time to do a massive exam. What do you want to do straight away?
I think at this point you'd assume sepsis, and you would get IV access and start some antibiotics and take all your bloods.
Yep. So this lady's been in ED for 12 hours. So thankfully she's already had bloods, and she's already had a dose of ceftriaxone. What are we going to do to actually treat the cardiovascular compromise?
Fluid resuscitation to begin with.
Yeah. So what sort of fluid do you want to give her?
Crystalloid usually.
Yeah. How much?
Start with it. It sounds like she's had a bit already, but start with a litre and see how she responds, then go another litre, then another.
Yeah. So what sort of limit would you put on how many litres? Any like rough thoughts in your experience?
I mean, she's young and healthy. She's probably got a fair bit of reserve.
Yep.
Her heart can probably cope with, 5 litres, 6 litres.
Oh, well, there you go. You picked it. So you got to write another litre of crystalloid to be given stat. She's already had 5 litres plus a little bit of oral fluid, and she hasn't voided or shift. Do you want to give her more fluid? She can take it.
Yeah, give her some more. But at this point, you want to start looking at probably vasopressor support, because she hasn't really picked up with this amount of fluid.
Yeah, so this lady is showing, and when you examine her, you see that she's actually quite warm peripherally with a very brisk capillary refill. Now, if you think about whether that's appropriate in this context, someone who's hypotensive and tachycardic, whose sympathetic nervous system is already going to overdrive, you'd expect them to be a little bit more peripherally shut down. So what sort of pathology, what sort of medical pathology do you think this girl is developing? Someone's already said it ages ago.
Shock?
Yeah, what sort of shock?
Distributive.
Absolutely. Do you want to have a crack at defining distributive shock, whoever that was? Disembodied voice.
So normally you've got dilation of the peripheral vasculature. So patients are hypertensive, tachycardic, but they are peripherally warm.
Yeah, that's right. So this lady, gram-negative rods, is probably an E. coli, which has some endotoxins, which has activated the immune system significantly. And distributive shock is where you get a reduction in effective circulating volume, such that you're not getting venous return back to the heart. So this lady hasn't lost blood. The blood isn't where it's meant to be. And that's something you have to think about as well. Is the blood where it's meant to be? Is the fluid where it's not meant to be? And is the blood made of the right stuff? So what is the definitive treatment of sepsis here? I think it was
Antes?
Yeah, antes. But if we wait for the antes to work and the blood's not really getting to where it needs to be, we have to temporize and we have to support our blood pressure. So whoever that was who said blood pressure support is really good, good thinking. And that's something you could say, you know, call your registrar, your consultant, say, I'm going to make a call from an 18-year-old. She's got distributive shock. She's oliguric and she's had 5 liters of fluid. I think she needs presses. And then straight away, like, that's not, again, not rocket science. The decision's been made for you. Somebody's already tried to flog it with fluid. That's a really good way of summarizing and sounding a lot more clinically knowledgeable. And of course, yeah, we'll go a little bit more about oliguria in a second. She needs invasive blood pressure monitoring. She needs fluid balance and she needs blood pressure support with noradrenaline infusion through a central line. So what's a normal urine output in mils per hour, per kilo per hour?
.5.
Yeah, about 0.5 to 1 mil per kilo per hour, give or take. But again, coming back to mean arterial pressure and why it's so important, if we have renal blood flow on the y-axis and mean arterial pressure on the x, we see that for a wide range in mean arterial pressures, renal blood flow is essentially the same, which is really good for the kidneys. Like, they're very, very good at regulating their own flow, but also causing hormonal changes to regulate the whole body's total body water content. But we see here, this 18-year-old, this previously well 18-year-old is likely falling off the back end of this curve and actually hypoperfusing her kidneys. So she's showing signs of severe sepsis as a result of distributive shock, and vasodilatory shock is another way of putting it. Keep in mind too, if you have someone who is hypertensive at baseline, this curve actually shifts to the right. So they might, rather than falling off the curve at, say, a mean arterial pressure of 60, they might start to fall off the curve at a mean arterial pressure of 80. So we have to keep that in mind when setting appropriate blood pressure targets when we're treating blood pressure as well. But in this previously well person, we could target a mean arterial pressure of 65. But yeah, keep in mind too, when you're on the ward and the nurse tells you, oh, so-and-so's urine output's dropped off, they've just come back from theatre, what do you want to do about it? Oliguria is a physiologic response to stress. It is normal if you've just had, say, a laparotomy or you've lost blood to actually become a little bit oliguric. The question then becomes, are they showing signs of end organ dysfunction as a result? Is there creatinine rising? Is it going to be a persistent drop in urine output? You know, are they hypotensive as well, or something else? Are their drains filling up with blood to be causing some other reason for them to be oliguric? So you have to keep looking for answers and don't flog someone with fluid. It is true this girl could take it, but it becomes more important as people get older and more frail and have other comorbidities. How are we going for time? We've got time for one more.
Yeah, we do.
Absolutely.
Pretty quick. So now we're at code blue. Things are getting a bit real. It's the middle of the night. You call to a code or you attend a code on behalf of your ICU or anaesthetics registrars for a lady who's essentially had a vomit and passed out on the ward. She's on the ward fasting for a scope. She's had hematemesis and melena, secondary to alcohol and NSAIDs. Everything like is chaos in the room. How are we going to support her?
I guess first thing is, does she have IV access?
Yep, she does.
So if she was for a scope tomorrow, does she already have a group and hold?
Yeah, these are good things. Let's take it back a step though. You've got someone who's vomited and there's been a call for suspected loss of consciousness. Anything you want to do before resuscitating it?
Check the airway.
Yeah, so always take it back to the simple stuff. When everything's getting crazy, always take it back to basic life support and then step it up to advanced life support if you can. And always be calling for help in these situations. Because someone who's supine, who may or not be conscious, is at risk of aspiration. So what can we do to prevent that right now? You can just put her on her side. Is a really useful thing to do. And while you're there, you can be checking a radial pulse. So again, if you can feel a radial pulse, then you know at least the systolic is around 80, which in the short term is at least compatible with life. So a few little simple things and just keeping it really basic. And when you feel that stress or that want to do something quickly, take it back to just following the rules, ABC, and you usually can't go wrong. So these sorts of situations can go one way or another. You'd be surprised someone can have continual torrential hemorrhage. If someone's had alcohol intake, what sort of bleeding are we worried about? Or excessive alcohol intake?
Esophageal varices.
Yeah, so there might be variceal bleeding, or there might be a peptic ulcer. And keep in mind too that when someone has a gastrointestinal bleeding, quite often it can be associated with syncopal episodes. So someone who presents to ED who's had abdominal pain, like a sudden bout of abdominal pain, and then syncope and then not quite right afterwards, might have a retroperitoneal bleed, for example. I've seen that a couple of times. And as a general rule, quantifying blood loss can be very, very difficult, particularly when it's around and spread on sheets and things like that. So a good way of knowing if someone's lost a significant amount of blood is just looking at their cardiovascular response. I do have a table down the track, but keep in mind that if we get to it, that is, usually someone has to lose probably 500 to 700 mils, 750 mils before they start to mount a significant tachycardic response or before they start to show profound hypotension. So what's the definitive management here?
It's going to be to go in with the scope and fix the point of bleeding.
Yeah, absolutely. What happens if they go in with a scope and they just lodge a clot and the patient starts hemorrhaging? Where are they going to go from there? Because that's what happened with this case.
Is it IR for embolization?
Yeah, so you've got a few options. It's usually consideration of laparotomy if you've mobilised enough of your team, if you've got surgeons around, or interventional radiology if they're available to your hospital and reasonably close by. So those are the things you have to be thinking of. Like, this could go one way, this patient could wake up and be fine, or they could continue to hemorrhage, or the intervention could actually cause more problem in the short term. And one thing that anaesthetic teams have to think about is what's the consequence of inducing anaesthesia on someone with profound hypovolemia? Anyone want to take a stab at what that might cause?
You can make them even more hypotensive. So would you be concerned about like a stroke?
Yeah, I mean, you could kill them. They could die on it. They could arrest on induction. They could be that, their intravascular space could be that empty that once you give them anesthesia medicines, they actually lose their blood pressure. So in the meantime, as a junior doctor, your job here as an initiated follower, it's not all about leading and telling people what to do. It's about knowing what to do and just getting it done sometimes. So IV access is really important. And when we talk about resuscitation, I think Hannah was asking earlier, does she have a group and hold, which is a really good question. Because yes, she's probably going to need blood. We need to think about resuscitating not only to volume targets and maintaining that pressure to give perfusion to the vital organs, but making sure that the blood is made of the right stuff. Because if you're losing blood, you want to replace with blood. I mean, yes, while you're waiting for blood, you can be giving fluids to maintain pressure at a survivable level. But the blood needs to be made of enough hemoglobin to actually deliver oxygen to the tissues. Does anyone know what sort of target you'd aim for of a hemoglobin in these sorts of situations?
Maybe about 70.
Yeah, usually 70 if someone doesn't have cardiac disease. The reasons for that are multiple, but often blood is expensive. Blood is very precious resource, it's limited resource. And each transfusion actually has risks as well in terms of triggering immune responses and overloading the circulatory system. So aiming to get someone back to where they were before they bled is not always practical or safe. And 70 is usually the safe point for being able to carry enough oxygen to the tissues. Any particular tests, bedside tests you want to do?
Might do a VBG for a lactate and a quick hemoglobin.
Sounds pretty good. Anything else you're going to get on the VBG that's going to be useful when someone's had syncope and is fasting?
I suppose you'll also get the glucose.
Yeah. So always, what is it? Don't ever forget glucose. Because you'd be surprised about what actually could be a red herring in situations like this. Because if this person has had a small vomit bleed and then syncope and never really recovered, but you don't know what's going on, and no one's thought to test those other things, you end up feeling a little bit sheepish. But yes, definitely definitely VBG and mobilising staff as well. I'll make this the last slide, unless people have time. So it is all about mean arterial pressure. We see on this graph, as cardiac output drops linearly and stroke volume drops even more rapidly, mean arterial pressure doesn't drop quite as aggressively. And why does the stroke volume drop a lot more than the cardiac output does? Why does this cardiac output line stay straight, but this purple stroke volume line drops off? What keeps the cardiac output stable?
Tachycardia.
Yeah, good on you. It is really basic stuff, but it can be quite confronting when you've got someone bleeding in front of you and you're trying to piece things together. But keep in mind that even if someone walks into ED with a vomit bag full of blood, they might be full, they've already started compensating. Our compensatory mechanisms are very, very good. And when people start to decompensate, that shows that they've probably already lost a significant amount of blood. Because we have immediate responses in terms of adrenal and adrenergic responses from the adrenal medulla, which is triggered by the brainstem's hemodynamic monitoring centers. And we also have the kidneys and the hypothalamus, which really kick into gear to help shift fluid back into the circulation to again boost it to maintain that pressure, to maintain perfusion to the organs. I think we can leave it there. I think that's the time, isn't it?
That's perfect. Thanks so much for that. We haven't yet got any questions in the Slido link. I'll send it through one more time in the chat. But otherwise, feel free to unmute yourself and ask.
I have a question for case 3. Is there any use for tranexamic acid?
Yeah, so good question. So tranexamic acid is an antifibrinolytic. And if this lady has been perhaps oozing blood over a number of days and the stomach is filling up with blood, for example, she might have sort of slowly run out of platelets or exhausted her fibrin supply. So you could give it as a temporizing measure. It's usually what you give when you're struggling to control the bleeding and when scope is underway, sort of thing. That's usually the point at which you're giving that. But you could give it during the actual initial arrest. I'm sure there's nothing to be lost from it. You'll get a talk on drugs. I'm sure Patrick will tell you everything about all that in 2 weeks.
Any other questions, anyone? Cool. Well, thanks so much, Greg. On behalf of everyone here tonight, and on PVACCS, thanks again for giving that talk. That was really awesome. Lots of interesting cases, and I'm sure we've all taken away many clinical pearls from that. To everyone else, stay tuned for the next part of our mini-series, which will be on drugs, presented by Dr. Patrick Beale in 2 weeks' time. We also have a careers night coming up later this year, so make sure you like our Facebook page and join as a member to our group so you can stay up to date. So thank you, everyone, and have a good night.
Thank you.
That was great. Thank you for that again.
That's okay. So that recording will just be available on your website, will it? Or
Yeah, so we have a